All right, so I'll get started tonight. Thank you everyone for being here, and looking forward to anyone else who trickles in tonight. Welcome to an AMSSM MSIG webinar. MSIG stands for Medical Student Interest Group. My name is Carly Setterburg, and I will be serving as the webinar moderator tonight. This past year, I served as the president of the AMSSM MSIG, and will be continuing to serve as the immediate past president for the 2024 calendar year. I am currently a fourth-year medical student at the University of Colorado School of Medicine. I'm originally from Glenwood Springs, Colorado, and went to Whitworth University in Spokane, Washington, where I studied health sciences. I also did a personal training internship there and ran track and field there, so this topic is very near and dear to my heart. And then I have been part of the AMSSM ever since my second year of medical school and have enjoyed coming to these webinars myself and participating in journal clubs. And we're hoping to continue this on in the future. Tonight, we're honored to have Dr. Robert Baker and Dr. Stacy Majoras serve as our speakers for our MSIG webinar, Barbell Injuries. And after their presentations, I'll be moderating a brief Q&A, so please enter your questions in the chat as they come along, and we can get those answered at the end. It's an honor to introduce our two speakers tonight, Dr. Robert Baker and Dr. Stacy Majoras. Dr. Baker received his medical degree in 1994 and his doctorate in 1995 from the University of Illinois Urbana-Champaign. And he has been a certified athletic trainer since 1986. He completed a residency in family medicine at MSU Kalamazoo Center for Medical Studies. And in 1999, he completed a fellowship for sports medicine at Michigan State University. Currently, Dr. Baker is director of the Primary Care Sports Medicine Fellowship at Western Michigan University School of Medicine Clinics. And in addition, he is the team physician for Western Michigan University and professor of clinical medicine at Western Michigan School of Medicine and Michigan State University. Dr. Baker has presented locally, regionally, and nationally on various topics in sports medicine and has published numerous articles and book chapters on these topics as well. He has practiced at Bronson Orthopedics and Sports Medicine since 1999. And as a primary care sports medicine physician, he sees patients and athletes of all ages and has particular areas of interest, including exercise-induced asthma, athletes with diabetes and other chronic diseases, back pain in adolescent and adult athletes, as well as non-surgical orthopedic injuries in athletes. Dr. Baker is a member of the American Institute for Ultrasound in Medicine, Michigan Academy of Family Physicians, and American Medical Society for Sports Medicine, and he is a fellow of the American College of Sports Medicine and a fellow of the American Academy of Family Physicians. He is a member of the National Athletic Trainers Association and served on the Board of Certification Standards of Practice Committee. Dr. Baker and his wife have 3 children, and he enjoys spending time with his family, traveling, camping, bicycling, and playing basketball. Dr. Majoras was born and raised in Auburn, Indiana, and graduated from Purdue University with a degree in athletic training. She earned her medical degree from Western University of Health Sciences College of Osteopathic Medicine of the Pacific and completed her family medicine residency at St. Joseph Regional Medical Center in South Bend, Indiana. She then completed a fellowship in sports medicine at Cleveland Clinic and is currently board certified family medicine physician with a CAQ of sports medicine and works at Bronson Sports Medicine. She is a team physician for Western Michigan University Athletics, Kalamazoo Wings Hockey Club, and various high school sports. She now resides in Vicksburg with her husband and 4 children. She enjoys running with her family and incorporating activity into her family's life. And now I'll go ahead and give the floor to our speakers if you want to share your slides.
Awesome. Well, thank you so much, everyone, for being here. Like Carly said, I'm Dr. Majoras. I actually work right next to Dr. Baker a lot. So it's very exciting to do this together with him. We're going to be talking about barbell injuries. And I will admit that I learned a lot doing this lecture. So we'll get started here with some objectives. I learned that a lot of definitions generally help when we're going through a lecture. This doesn't seem to be a topic that is widely spread. So I want to kind of introduce some ideas in the weight room so that when we're talking about form or injury, what you can understand what we're saying. I'm going to talk about the techniques and tips to avoid injuries, and then I'll hand it over to Dr. Baker for those injuries and treatments for a second. So first and foremost, there are a lot of different types of bars. There are dive bars. There are karaoke bars. My favorite are the bougie bars. But last but not least, no one on this lecture is going to get this joke except Dr. Baker. We're bars where everyone knows your name. So if you don't know Cheers, please give an old lady a bone and go watch the reruns on YouTube. So anyway, so bars, barbells. Barbell is a piece of equipment comprised of variable lengths and typically weights that you put on the end. You can see the myriad of different bars that are here. I don't know if you can see my arrow as I'm kind of moving it around, but the hex bar, oh, sorry, let me go back. The hex bar is the bar up in the top right corner there that looks like a hexagon. There are the easy curl bars. Those weights are actually firmly attached to the end, so that's not a bar where you take them on and off, but it's got easy grip for your hands to kind of move. You have your rack where you put your weights or your bar after you're done. That's kind of up in the right-hand corner as well. And then clips go on the end of the bar. We don't go into that very much, but clips can be kind of controversial here and there depending on who you talk to. And then a safety bar is the one where the guy is squatting at the top there. Anyone who has a shoulder injury or some sort of upper extremity issue that they can't put their shoulder in that backward position to grab a hold of a squat bar, that is a safety bar to help kind of offload the shoulder joint. So just those few definitions, we're going to go into techniques. I wanted to start by just kind of saying, you know, barbell injuries or weightlifting injuries in general are fairly rare. I did a few article lit search on how likely it would be. The CrossFit article is always tough because there's so many different things on that article, not just barbell injuries. So that's kind of why it's 0.2 to up to 18.9 on the injuries. But the powerlifting was definitely that 0.3. There's a systematic review of just regular powerlifting and regular weightlifting. Again, 2.4. And then youth weightlifters, so any adolescents between the ages of 13 and 18 was about 0.9. So there's a little bit of variability, but overall, amongst all the people who do some sort of weightlifting at any age, it's a pretty low risk. So we'll kind of go into how to avoid those injuries. I picked a few topics here just to kind of cover. There's a bunch of ways you can avoid injury. The biggest one at the top there, how to choose your barbell. I had to do a lot of research on how to choose your barbell because it's very interesting how many are out there. And it depends on what you're lifting. So if you're going to the gym and there's a bunch of racks and you've got bench press and you got squat and you've got just regular bars just sitting out to the side, there are different ones for different things. There's also a male versus female bar, knowing the biomechanics of the shoulder and the differences just in the size of women versus men. There are shorter and smaller bars to decrease the risk of injury, especially at the shoulder level. The next one would be the correct lift technique. So a lot of people do not know how to lift weights, and a lot of people just kind of go out there and wing it, and that's a big reason for injury. Choosing your weight. If you're just starting out and you go to the gym and you throw on 50 pounds each side and you don't know that you can't lift 50 pounds, that's a problem. So getting an expert or someone to help you start. And then when we're talking about the elite weightlifters and their max weight testing, kind of those 1 rep max things, you got to know how to pick your max. And then check your environment. So anytime you're doing something such as weightlifting, you definitely want to make sure you're looking around. I can kind of angle this into the sports medicine world. If somebody gets hurt and you're running onto the field to see if anybody's okay, the first thing you do is look around, and then check your outfit. You know, we're not being fancy schmancy at the gym. And so you got to make sure you're in the right outfit to make sure that you're not creating any injury for yourself or anyone else. So I'll go into a couple of these, but a bigger issue that I see, and I've seen a few times in the office, is what your risk is when you decide to take supplements or other testosterone anabolic steroids. There's tons of great literature to show that testosterone supplements are tainted. There's also, I'll get into that a little bit later. There's also an abundance, I'll say, of literature about anabolic steroid use and injury to athletes, not just tendon ruptures, but other metabolic issues. You get liver failure, kidney failure, you can get heart and vascular issues, anger issues, mental health problems, reproductive issues. And so while they're extremely widely used, the world of anabolic steroids is a really dangerous one. So checking your risk at the door, just using your own body to build strength would probably be where I would start. So on to choosing the right bar. The hex bar up here, you can kind of see it doesn't change their form, but it changes their grip and how they do things. You also have the different bars listed down there. A lot of them will change based on grip. So you can see some of them are shaded. That's in where the grip handle is. There's some that have longer weight areas, they're shorter. And then there are some that have a little more bend or flexibility to them. So all of these, you know, you look at that picture like, oh, they all look like bars and one's a little shorter, but they all have different characteristics to them. So depending on what your goal is or what your level of expertise is, if you really got to get a grip on that bar, you might want to have one that's got a grip and you might want to wear gloves with it. So the right bar there, I kind of have the different deadlifts. So if you're talking to someone and they say they're a power lifter, the major three that they do is the squat, the deadlift, and the bench press. If you're an Olympic lifter, that's a snatch, a clean, and a jerk. And then if you're the weekend warrior, you're liable to do just about anything your buddies ask you to do. So I'm going to just go, I use a lot of pictures. I'm a visual learner. So when you look at these pictures, it's kind of looking at proper technique. So this lady off here to the left, rocking it out just like perfect over there. And she's got the benefits of all of those massive muscles that I wish I had. And then you kind of look at this other one over here. The big thing I'm going to point out is her shoulders. A lot of people have really weak hips. If you want to do some really good lit searches, look at the prevalence of hip weakness and a lot of injuries, especially lower extremity. And so what she's demonstrating there is she's using her low back and the improper squat on the bottom, stressing that low back and using her really tiny fatigable muscles instead of using her glutes, her quads, and her hammies. So big thing with the squat, don't bend forward. And try to keep your ears, your shoulders, your ankles all kind of in alignment. The next is the deadlift. This is another one that's extremely common for people to get hurt. Again, you kind of see the wrong versus the right. You definitely want to keep your shoulders, your knees, and your ankles kind of in this somewhat of a line, and with that bar there. This is why a lot of people will use the hex bar that you saw earlier for the deadlift, because then they don't have to reach over their knees or their shins and get a big shin scrape, which you'll see later with Dr. Baker. And when you get your glutes dropped too low, you're engaging your low back. You take out your core, and then you really have to demand a lot from that knee in those angles. So deadlift, another big one for back and knee injuries. The bench press, this is a big one. This guy right here on the left that's benching, I'm pretty sure the very next picture I found of him was rupturing his pec. So one of the techniques that we look, you kind of see the bottom position, top position. You really don't want your shoulder and your elbow to go past 90 degrees at the bottom, because that increases the stress on the capsule of the shoulder. Even when you kind of keep those elbows tucked, you don't go past the level of your chest. That can also help decrease the risk of injury when you're talking about crush injuries to the chest, If you've got a bar out here and you can kind of push with it, that's better than if you're, I'm trying to demonstrate where your elbow is back and now you have to use your pec even more to push it off your chest. And so Dr. Baker will talk about that a little bit later in pec injuries and weightlifting crush injuries on the chest and how to kind of bail out of those. But the biggest is you can kind of see this guy has clips on his. So we talk about fail to bail. If you're failing at this position, you want to bail out. And if you bail out to the side and you can't dump the weight, that can cause other injuries. So that's a big one with the bench press and the squat really too. I didn't mention. Oh, and then if I go back, sorry, I'm gonna go back one. So the bench press, the other thing too, is you see his feet flat on the floor. So that's also a very, very important positioning and technique. So when you got your bench press machine, you got to make sure it's low enough. There's all different sizes of people. And there's a lot of us that are shorter than others. So if you're benching, you don't want to put your feet up on the board or on the bench, and you don't want them dangling, and you don't want to use your tippy toes. You want to have that as leverage because your core should be the strongest part of your body. And that's where your legs kind of help stabilize. And then onto a snatch. I have a couple different pictures here. This is a weightlifter from the Olympics, and he goes through each stage of how this goes. Once these dynamic lifts become more and more popular, these also have an increased risk of injury. So this is a one fluid motion. This is not just like a I'm going to do a bench press where I push up and push down. This guy is got to do multiple different bends and twists and keep the knees and the hips in the proper alignment. And if he doesn't, then he's going to get injured. That picture 5 there at the end, it kind of demonstrates the bar back a little bit further than what I would like it to be. Usually you want your shoulders a little bit more forward. They are back a little, but you want to tuck that chin back and that head back and really stabilize at the scapula there so that you don't pop out of socket. So big issue with the snatch. You've definitely got to do it all in one motion from the base all the way to the top. If you stop, you're going to kind of get stuck. The next one is the clean and jerk. This is another one, just like the snatch. This is an Olympic weightlift. That lady from the Philippines right there is freaking awesome. I watched her live when she was in the Olympics. So she, again, you can kind of see that bar is directly over her head, not back at all. So you kind of have to get your shoulders locked into position over your hips. If you can see my pointer, hopefully, his hips go from a backward position, you thrust forward, and then as he pushes overhead, he has to keep his shoulders, his hips, and his head in alignment, and then those shoulders go right up over the top. And if at any point in time, again, you lose your balance, fail to bail, you got to get that bar out of your hands and tilt to the side. But this is another one. If you're not doing the correct form, then you're going to get hurt. So I'll go into picking the correct weight in a minute, but I just want to point out here too, if you're doing too much weight because you're a beginner and you're not really sure, always just start with the bar. And if you're not strong enough to hold up the bar, start with body weight. Just do it, the motion, and see yourself in the mirror and make sure you're doing it right. And if you don't know, get a trainer or somebody who does know. So how do you choose the correct weight? This is just a little chart that I found in one of the articles on kind of how many reps and then what it's accomplishing. So you always hear people talk about 1 rep max. That's supposed to be your number one high intensity. It's the only weight you can lift once ever. Funny thing is when you're testing your 1 rep max, you do it more than once. So there's always, I think that's just hilarious. But you want to start low. You want to try to see, just like I said, body weight first, and then move up into just a bar or a dumbbell that's like 1 or 2 pounds, and then you move up from there. And depending on what weight you use, if you want to use dumbbells versus bars, if you want to make sure that you have strength in both arms, test out each arm and see what you can lift. Everybody usually has a dominant, so that does take effect. If you're an intermediate lifter, then that's where you really hone in on what your technique is and how to increase your technique in your kind of your physics. So I love this topic because it's physics and I'm a big nerd. And so if you get your physics just right, you can lift more weight and become stronger. So That intermediate, I find, is where most people live, that either, you're a college athlete, a high school athlete, you took a class, you go to the gym 2-3 times a week, you have a program, you lift things up. So intermediate is where I find a lot of our athletes to sit. And then the advanced, that's where I see my professional and collegiate athletes that are currently in the weight room, doing a ton of stuff, getting extra swole, if you will. And then you kind of think about this, the weekend warrior, if you will. The guy on the left is obviously not a weekend warrior. But what about that old guy at the gym too? You guys see him over there doing his little calisthenics. Found a great article out of Michigan State about masters athletes and weightlifting. And so when you look at that, the biggest thing I found, obviously, the introduction to the article is, hey, old people can lift weights too. And I was like, well, duh. But when you look into the nitty gritty of it, it really talked about the sex differences between men and women and how estrogen and testosterone work. And then once you go postmenopausal and men start losing testosterone levels, we all kind of even out. The biggest thing between both groups is fatigue. We're not 20 anymore, and so our muscles and tendons and things don't bounce back like they used to. And so we old people have to be careful that we don't lift what we did when we were 30 or 20 or 15 or 10. We got to really pay attention to what we're doing to the body at that level. The next would be check your environment. So I found this really cool picture on Pinterest. I was like, wow, it would be really great if everybody had a home gym in their garage like that. And then I was like, where do they park their car? Because here in Michigan, you don't park your car outside unless you have to. And so I think that's probably California or Arizona or somewhere really fun to go, than not in the cold. But you also have to be careful that you're not walking into that either. I'm sure you could lift some really good weights in that gym, but you might get a splinter in your rear end. So be careful. And then your style. So what do you want to look like when you go to the gym and match your shorts to your shirt and, have your headband on? But you definitely want to consider gloves if you're grabbing a bar. Dr. Baker's going to talk very shortly about blisters and rips in the hands. Those gloves are vital. They also help improve grip, and so does like powder. So definitely think about that. Straps are controversial. You can see there down at the bottom left here, there's a strap that holds you onto the bar. The problem with that is, what if you're got a bail? And then now the bar is attached to your hand and now your elbow's dislocated. So they're kind of controversial, but if you're an expertise in weightlifting and you feel comfortable with it, it's not a bad idea. And then the other one is a grip for, maybe you got hand arthritis or had to have surgery or something on the hand or wrist. That clips onto the bar and it allows the weight to be distributed differently. I love my shoes. Love my shoes, but there are definitely shoes you wear in the weight room and there are shoes you don't. And so those shoes right there just have a nice grip on them. Make sure your shoelaces are all tucked in so they don't get caught on anything. I don't know why this guy's barefoot lifting. I am a big proponent of barefoot walking and barefoot everything, but I don't lift weights barefoot because I like my toes and they're pretty. So this is Venice Beach. Even those crazy guys there, they just got out of the water, it looks like. They're all barefoot, but if you keep looking at their pictures, they end up putting shoes on later. I would not recommend heels in the gym. I don't know what these ladies are doing here, but I think hopefully they were just there for show. And then lastly, your clothing. You don't really want to wear big baggy clothes if you're weightlifting. You can get that caught in a bar or a clip. You can, slip. You want to wear a nice form-fitting shirt and nice form-fitting shorts and make sure that you're covered appropriately so that the bar doesn't rip or tear any parts of your body. So that is it. Hopefully I didn't take up too much of Dr. Baker's time because he's got a lot of injuries to go to. So I am going to hop out and let him go.
All right. Hopefully you're seeing my slides. So once again, back to the title slide. And I think this title slide demonstrates the ultimate in arrogance anybody who has more initials behind their name than in their name is probably pretty arrogant. But I wanted to give you a feel for my background, MD, PhD, exercise physiology, and then, as was mentioned by Carly, fellow in those organizations, and then athletic trainer as well. So Stacy and I come from a similar background in terms of athletic training education. So, and certainly we can answer some questions about that along the way. But I'm going to talk about common type injuries. Divide these up a little bit here and talk about them in clusters, but think about the first things here: the blisters, skin abrasions, contusions, hemorrhage, crush injuries, fractures, usually more commonly due to injuries related to the weights and direct trauma from the weights, etc. Next, consider injuries that occur with hello. Injuries that occur with overexertion. So your shoulder injuries, joint dislocations, and then also muscle tendon strains and tears. We'll talk about a few of these and some of the anatomy involved with this. And then finally, head injuries and spine injuries that kind of cross the gamut of both trauma related as well as overexertion type injuries. If you look by weight and the occurrence of injuries, this was a study that looked at different age groups. Looking first at the young age group, kids under the age of 13, fairly safe activity. You saw that Dr. Majoras presented the overall numbers on this, and the injury rate is fairly low. Majority of these happen due usually to trauma, etc. So injuries to the head, injuries to the hand and foot from primarily dropped weights, etc. As you get into older age groups, 19 and beyond, more overuse type, overexertion type injuries. So more commonly upper trunk, lower trunk type injuries in particular. And that's borne out when you look at mechanisms here. This under the 13 age group, nearly 80% are from dropped weights. And still a high percentage of other groups, but the highest percentage in the under 13 age group. And then you see this increase in the age groups from 19 on, where you have overexertion. So we'll talk about some injuries related to overexertion as well, primarily as I presented earlier, the muscle tears and dislocations and joint injuries. So common injuries, we'll start with blisters, skin abrasions, contusions, and hemorrhages, primarily from soft tissue on the skin. And we'll take a look at some of these. Blisters, primarily on the hands from gripping. And you can see on the upper right-hand part of the screen, blisters and rips on the palm of the hand, over the ball of the hand primarily, where they can callus and then underneath develop blisters and rips, much like we see in gymnasts and things of that nature. You want to keep these clean and dry. Consider using gloves as a way to avoid this, chalk as a way to avoid this as well. Or if there is an injury, you need to cover it using gloves at that time. And from experience, one of the common things that we use with gymnasts for rips that we found helps with numbing is actually chloroseptic. Can be an effective analgesic for these types of rips. As Dr. Majoras talked about, in the middle of the screen there, abrasions from some bar tracks along the lower shin from poor technique, as she talked about. And then finally, contusions down in the lower right-hand corner of the screen there, usually from trauma from the weights themselves. All right, a little bit about Valsalva, common maneuver that's performed by weightlifters. Advantage or disadvantage, we don't know, but we do have concerns with this in terms of what it does to pressures. Obviously, this is contraction of the abdominal muscles, the chest wall muscles, as well as the back muscles, against a closed glottis. So pressures develop into the chest. So interthoracic pressure and intra-abdominal pressure will increase, causing possibility of injuries in these areas, specifically in the abdominal area, hernias, and we'll talk about prolapse as well. Along with this, in the chest, there can be increase in blood pressure, which can result in increase in intracranial pressure and cause possible hemorrhages in other locations as well. Eventually, over time, you release the Valsalva maneuver and you get a decrease in interthoracic, intra-abdominal pressures, decrease in blood flow. Usually heart rate stays up and cranial pressure decreases. So this is kind of the basis of a lot of the overexertion type injuries that we're going to talk about in terms of or relationship to hemorrhage to start with here. So increased pressures within the tissue can cause upper right hand corner here, petechia that you see on the leg, blood vessels that bleed a little bit underneath the skin. You can also see some of these punctate hemorrhages that occur in the hand, either due to direct pressure or increase in intracranial pressure or intravascular pressure, as well as direct trauma. They like to ask this question. I always tell our fellows and our residents, as well as our medical students, I just teach towards the exam. They're going to ask you questions about this. They like to show you this picture of talon noyure. This is actually on the hand, but talon noyure often occurs from pressures on the heel, etc. You get this punctate bleeding underneath the skin that gets darkened in an area. And it's a lookalike. That's why they ask you the question. It's a lookalike. Looks like melanoma. How do you know it's not? Well, from the punctate appearance in the skin and the location and the association of trauma. You can see other types of hemorrhages. Of course, retinal hemorrhage within the eye itself. Blood vessels can rupture, and you see a picture here of the optic disc in the retina with a nice large hemorrhage. And this can affect vision, etc. So this is a great concern. You can also get subconjunctival hemorrhages just from the intracranial and intra-abdominal pressures that are developed from that Valsalva maneuver, and see these subconjunctival hemorrhages within the eye. On the outside, on the sclera, which are pretty much benign, will resolve on their own. Finally, increase abdominal pressure and increase intracranial pressure, possibly related to some hemorrhages in these areas as well. All right, we'll move on. Talk a little bit about muscle and tendon strains and tears. Looking at the pectoralis and the biceps in particular. So we'll start with the biceps here and the classic Popeye deformity. That's demonstrated in this picture here, primarily related to a proximal tendon rupture in the shoulder because of the tension of the muscle. This muscle shortens up, just like the old time shades, you pull them and they kind of flip all the way up. That's what happens to this muscle. It shortens all the way down. It's under so much tension here. Proximal tendon tears of the biceps we're not quite as concerned about, but distals are the bad actors. These tend to lend to a lot more disability, and we'll talk about from an anatomical standpoint why that might be the case. Demonstrated up here in the corner in this picture is bruising that you might see, dependent bruising. Could be from a muscle mid-substance tear or tendon tear that's proximal, or it could be distal as well. But that's the kind of presentation that you will see in terms of bleeding underneath the skin. Often missed are these distal biceps tendon tears. Difficult to examine, as you can see in the picture in the upper left-hand corner with all that bruising, swelling. Sometimes difficult to identify the biceps tendon itself. You really need to use this hook test, get your finger in there, try to hook around that distal biceps tendon to diagnose a distal biceps tendon tear. while the proximal tears, you tend to see this Popeye deformity. You tend to not see the Popeye deformity with more distal type biceps tears, and that's because of the anatomy. If you look at the anatomical picture here of the biceps tendon, the arrow is showing you long head of biceps that comes over top of the humerus, dives deep and attaches to the glenoid fossa superiorly. We have the short head of the biceps tendon that attaches to this coracoid process. And then distally, though, you have the tendon that dives deep, and distally it attaches to the tuberosity on the radius. But there's also this, that's the distal attachment. There's also this lacertus insertion as well, a fibrous insertion that occurs over top of the antecubital fossa. And this usually doesn't tear, but rather holds the biceps tendon out to length. So you don't appreciate a Popeye deformity because the muscle doesn't shorten up quite as much as you would see in a more proximal biceps tendon rupture. So this is the type of thing that you really need to pay attention to. Good physical exam technique, and be aware, looking for a distal biceps tendon tear. The proximal ones, easy to diagnose. Distal tears, much more difficult to diagnose. You want to think about other types of factors. Are they using steroids or something like that that's causing or contributing to a distal biceps tear? And this is the one that you don't want to miss, because this will lead to significant disability in the elbow and the forearm. We saw somebody just in the office the other day. They present with the significant weakness with not so much flexion of the elbow, but supination, pronation of the elbow. It's a major supinator. So remember the biceps of major supinator. They're going to have difficulties twisting the jar on the peanut butter. So that's kind of the classic thing that folks present with this. And the misconception is that the biceps is a flexor tendon muscle unit. It's actually a major supinator. So another question they'll ask you on the exam. All right. Let's see here. Oops. There we go. All right. We'll move on to the pectoralis major. Once again, pectoralis major tears are common. Dr. Majoras alluded to that a little bit. Pectoralis minor tears we're less concerned about. Here's a classical presentation of a pectoralis tendon tear. You can see, if you compare the chest wall from one side to the other side, you can see this deficit and divot over the area of the pectoralis. Almost always these tear at the attachment of the upper arm or the humerus and leave this defect of the chest wall that you see on one side compared to the other side. Sometimes if you have them press their hands together, you'll bring out this defect a little bit more significantly. These are once again indication for surgical fixation, repair, to return normal function to the body. In the anatomical picture here, it's demonstrated both the pectoralis major, its attachment more proximally to the sternum, the clavicle, and the costochondral joint, and then distally the attachment to a ridge on the humerus, just over the biceps, and I'll show you some pictures of that. This can easily be diagnosed with use of ultrasound in our office, and we can give our orthopedic colleagues some information about pectoralis tear. Usually it's primarily clinical type diagnosis, but we can clarify where that tear occurs, whether it's mid-substance of the muscle, in the tendon, or deep or superficial layers. So surgical for the most part in the case of acute tendon ruptures, usually it's full thickness, and usually it's at the attachment or near the attachment on the humerus itself. Here's a ultrasound of the upper arm with a short axis onto the humerus, long axis to the pectoralis tendon. This lower picture here, you can see some of this is a partial tear, but you can see some of the hyperechoic area of the pectoralis tendon coming over and attaching normally to the humerus at a ridge, just overlying the biceps that's deep to that structure. On the upper panel here of the ultrasound, you can see the arrows showing the area of deficit where the tendon has torn. And rather than being hyperechoic, it's hypoechoic in the area, filling in with some most likely hematoma in this area. And then the arrowhead is pointing at the end of that muscle tendon unit that has shortened up from the tension on the muscle unit. All the way over here on the right, different types of muscle tears of the pectoralis. You can have muscle tears that occur more proximally at the sternum, clavicle, and ribs. Usually these we don't address. Those are not repaired. And then mid-substance tears also of pectoralis, impossible to repair. So those are usually treated non-operatively. The ones we're concerned about are where this tendon tears off, and most commonly this is at either the myotendinous junction or the tendinous intratendinous, or at the humeral insertion on the upper arm, and all of those can and should be repaired. Occasionally on the bottom there you can see the bony avulsion type mechanism, and that one can be repaired as well and should be repaired to return normal function to the upper extremity. All right. Oh, here's the ultrasound. I showed you the picture of this. The red represents the ultrasound head. You can slide down short axis to the upper arm, see the biceps tendon. You follow it down until you start to see the biceps tendon and biceps muscle junction, and that's where you're going to see the pectoralis overlying, and you'll get the pictures that were demonstrated there in AMB. All right, moving on to crush injuries and fractures. Common fractures to the hand and the finger here demonstrated a oblique fracture of the proximal phalanx. These are sometimes difficult to deal with, can have a significant amount of shortening and rotation of the finger. The more proximal the fracture is, the more likely it is to rotate. These need to be generally reduced. May need surgery to hold them in place, especially if there is a significant amount of rotation of the fingers themselves, otherwise casted and splinted. Crush injuries are always a concern. You can have traumatic amputations secondary to the crush injuries, and so further workup almost always is required for something like this. CT scan or MRI to take a look at the soft tissue and the integrity of the soft tissue. All right, moving on. Shoulder injuries, the slap, tear, and joint dislocations. Common joints are shoulder. I'll demonstrate a couple of techniques of shoulder reduction that are kind of nice. Elbow, finger, patella dislocations I'll demonstrate. And then the SC joint, but also the AC joint can have dislocations as well. Or in those cases, we call them separations. So starting up at the shoulder, slap tear. Slap tear is a superior labral injury and tear anterior to posterior, occurring approximately at the level of this long head of biceps. Attachment both on the glenoid, and then also some fibers are sent to this labrum as well. Some of these are non-surgical, depending on the size and the grading of the tears. Some we can manage with intra-articular injections to calm down the pain and move on with physical therapy. If the tears are large and compromise stability of the shoulder, then you're talking surgical repair of the slap lesion. Joint dislocations on the left side of the screen there demonstrated fingers, dorsal dislocation in B, most common type, This is at the DIP joint, but can also occur at other joints such as the PIP or proximal interphalangeal joint. On the right side of the screen, you can see a shoulder dislocation with a classic presentation where you see the squaring off of the shoulder, if you will, underneath the acromion. The humerus has slipped down both anterior and inferior, which is the most common direction of dislocation. Hard to see here, but you might see a little ball over the anterior aspect of the normal location of the shoulder. If you compare one side to the other side, you can see the injured side has this nice square cutoff or drop off of the shoulder, whereas there's much more rounding of the shoulders on the normal side. Some other dislocations you can see, patella, almost always dislocation is to the lateral side. The white arrow in the picture to the left demonstrates the patella located on just lateral to the lateral femoral condyle. The blue arrow points to the medial patellofemoral ligament that holds it in place, has been completely torn. And the red shows the trochlea where that normal patella should be located at. So this is a patellar dislocation. The middle picture, you see a SC separation where the clavicle has overridden, gone anterior to the sternum. You hope that that's the case. This oftentimes is non-surgical. However, if the dislocation is posterior, it's one of the few musculoskeletal injuries that are emergent or urgent for reduction. You have a lot of important stuff back behind that clavicle that can get injured, including the airway, the food tube, as well as arteries that lead to the head and the brain. So most often, fortunately, these SC separations occur anterior to the sternum, but if there's a posterior dislocation to the sternum, that's a medical emergency. And then you can see this fella here, weightlifter, that's his elbow and shoulder is just totally wrong. So that's most likely a fracture dislocation when you see something like that. Relocation, best done early on before the muscles have tightened up and work against you. You get 1 or 2 tries. Usually if you do attempt this in the field, muscles haven't spasmed up yet, and usually you do pretty good with reducing these, especially on shoulders. Sometimes on elbows as well. Fingers are good ones to reduce in the field as well. Consider the possibility of fracture with the dislocation, so it can either occur with the injury or with the reduction maneuver. As long as you don't try too many times or put over pressure on, you're pretty safe with not fracturing with your reduction procedure, but those can happen. So most of these eventually need to be x-rayed. May need some form of sedation to eventually get in or reduce the joint, especially in the shoulder, especially in someone who's a weightlifter and well muscular. Traction, distraction, generally the best way to go with reduction of these injuries. You get the muscle spasm to resolve, and then usually the joints reduce on their own. Nice technique here down on the bottom, the self-reduction technique, where you use your hands clasped around your knee and just kind of sit back, and you can reduce your shoulder on your own. And safe technique to use, good technique if you're by yourself. The technique I like for shoulder reduction, and there's tons of different reductions, but the success that I have with generally weightlifters is externally rotating the elbow and then flexing the arm up overhead, and almost always these will reduce the dislocation. Prolapse can occur from increased inter-abdominal pressure that we saw with the Valsalva. This is once again a surgical type problem, needs to be repaired, but you can have rectal prolapse in response to that increased abdominal pressure. And then finally, head and spine injuries can occur. Skull fractures, usually from the weights. This poor unfortunate soul dropped the weight on himself and hit the head. It can cause fracture of the skull, head injury, concussion, and at the least hematoma. Some controversy about do you use clips or don't you use clips. Bench pressing, some people will argue no use of clips allows the weights to fall off one side, and hopefully you can bail out a little bit easier. You can see that in this picture here where these weights are starting to slide down the bar, and once the weights are bailed out, then you can bail out and push the bar over is the hope. And then finally, spine injuries, either from increased pressures like I talked about, overuse, although the discs are fairly resistant to axial compression, twisting turning mechanisms often are introduced with weightlifting, especially with the bar, and can introduce some injury to these structures as well. Obviously, overuse with muscle strain and the possibility of degenerative changes over time. Looking at this spine, you can see a loss of the normal lordotic curve. So the spine has straightened out a bit, primarily related to loss of muscle tightness or muscle spasm, secondary to muscle strain. Down here, you can see at this level, disc space narrowing, most likely secondary to disc herniation and chronic changes. So that's disc space narrowing and herniation. With the degenerative changes, you can have some shifting, as we see at this level here. And this is spondylolisthesis or slippage of one level on another. Certainly a concern is compromise or injury that can occur to nerve roots and cause neurological problems as well. That's what I had prepared for injuries, and I will leave the rest of the time for questions.
Excellent. Thank you so much, Dr. Baker and Dr. Majoras. Those were both great presentations, and I think focused on not only like proper form and just the basics of a lot of lifting, but also the common injuries and treatments for which we have those lifting injuries. So one more thing before we get to the Q&A, because you're both physicians and athletic or certified athletic trainers, I was curious how, or if you would be willing to share how your medical practice is like positively impacted by your dual certifications and how you see that come to light in your practice.
Yeah, so I'll go first, and Bob, I'll give you a break. I actually never really even thought about being a doctor until my athletic trainer at Purdue recommended doing something with my life other than, just continuing to be a student. And so it's really, I think, a leg up. And we took probably 3 or 4 different anatomy classes while we were in athletic training school. And then you get into any kind of grad school, and then you go to medical school. Anatomy was a walk in the park because we had already done everything. And then you do all of your evaluations of athletes, and you figure out how to put rehab programs together. How to make pads. I remember, I'm sure Bob has done the same, but making a felt donut pad for an athlete to offload an area and injury, so those are kind of the things that, athletic trainers are just so versatile, and they can do pretty much anything with a popsicle stick. So I do think that it adds quite a bit to our practice that we can appreciate. I think number one, we can appreciate what they do for our athletes and understand where they're coming from. And then we also know what they're capable of. So I think it's always been a love of mine with sports. So I think being an athletic trainer is just awesome.
I was actually an athletic trainer in high school. and went on and enjoyed what I was doing. And then in college, same thing. I kind of wanted to get more involved in the diagnosis of and treatment of athletes and injuries. And it's been invaluable to kind of know how things work on the sidelines. It is the ultimate teamwork environment. So we have consultants that we work with on the sidelines. We have our neurologists that we work with. We have other folks, cardiologists, orthopedic, and managing that and managing your consultants, communicating between everybody is kind of the challenge, and you have to work as a team. And I think the biggest indication of the teamwork is that when we're on the sidelines, Dr. Majoras will attest to this, there's very little communication that happens. So when we see an injury, we know when we need to step up. If it's injury that I'm going to deal with, abdominal injury, trauma, those types of things, I'll take over on that. If it's musculoskeletal in nature, our orthopedic folks will take over on that. And then if it's head injury, concussion, then our neurological folks take over on that. So it's really prepared me for how you should operate as a physician with all those different folks around you that have their expertise and their specialties, and they know when to step in and take over and drive the ship. And we just kind of stand back and let our good people take care of folks. So that's where I think that athletic training program has benefited me the most, in really understanding, the specifics of what goes on the sidelines, but then applying that to kind of the teamwork in the office.
Yeah, thanks so much for sharing. I appreciate it. All right, looks like we have a few questions in the chat that we can answer. What is the optimal time frame to do a relocation before muscle spasms and other complications set in?
As soon as you make the diagnosis is the best time to do that. And I really think it's a compassion type thing. I mean, you want to reduce that to reduce their pain. It will be the first reduction that you do. It will be so rewarding because they come in, they're painful, uncomfortable. You reduce the joint and the pain goes away. So really, really good success with something like that. If it doesn't, then that tells you that something else is going on. I always remember one of my colleagues that worked with our team physician at Illinois and diagnosed a shoulder dislocation. They took the football player into the locker room and performed the maneuver and reduced the shoulder. And afterwards, the athlete was still painful. And that's when our orthopedic team physician said, okay, the athlete's still painful. What does that tell you? It tells you that it's got something else going on besides a shoulder dislocation. So you want to think about those things. You want to be compassionate about it, even though most, and I think I saw something in the chat about this, most reductions, I think it's reasonable after you do the reduction, at least to get an x-ray, document that the joint is reduced, and document any type of injury or fracture that has occurred. We had, there is some controversy amongst us, orthopedic, primary care, in terms of some of the other non-typical dislocation, elbows. Folks will argue, well, you know what, you're going to go in anyway. Should you do an x-ray before you do the reduction of the elbow, and then after the reduction of the elbow, just to document what occurred, if it occurred with the injury or occurred with the reduction? Not a bad thing to think about, but once again, I come back to the fact that the best time to reduce that with the least complications is going to be early on. So I think from a compassion type thing, for me, it's an individual type thing. It depends on your comfort with doing those procedures. But I would take a shot at reducing the elbow, knowing what your limitations are, and knowing that if you can't get it reduced with a good try, use the right mechanism, then you kind of move on with something like that and you don't force it. So as long as you do it responsibly, I think it's a reasonable thing to at least take a shot at and try out in the field. to really relieve some folks' pain, discomfort, with the idea knowing that, you know what, they're probably going to have to go in and get an x-ray anyways.
I agree 100%. To bring that athletic training back into it too, our head athletic trainers always taught us, you reduce it on the field as you're walking off. You know, you want to distract them, tell them something funny, get them to laugh, and then boom, get it back in. So yeah, I would agree 100%. Try right away as soon as you can get it, you know, and if you can't get it, then figure out something else.
All right. Well, just to be mindful of everyone's time tonight, if there's no more questions, I'm sure we can field some at another date if you want to email us or check us out on Instagram or Twitter. We're active on there. But on behalf of all the members in attendance tonight, I'd like to thank Dr. Majoras and Dr. Baker for taking the time from your busy schedules to spend time with all of us tonight and sharing valuable information on proper technique and also injuries and treatments for those barbell injuries. Just so we all know, the MSIG webinar Sideline Management, a two-part series, it was scheduled for next Monday, January 29th, and Tuesday, January 30th, has been postponed due to unforeseen circumstances, but we will be rescheduling it. So look out for a updated date on that. And then looking forward to February, there will be 3 journal club meetings, with the first meeting scheduled on February 1st at 8:30 p.m. Eastern Time, featuring 3 presentations. There will be 2 primary authors serving as the club mentors at that meeting, Dr. Jonathan Dresner and Dr. Holly Benjamin. And then our second meeting is scheduled at 8:30 p.m. Eastern Time on February 8th. And then the third meeting will be scheduled later in February, date TBD, but keep an eye out for that as well. I hope that you all make plans to join us. And I'd like to thank everyone attending tonight's MSIG webinar. It is my pleasure serving as the moderator tonight. And this concludes tonight's webinar session.
Thank you, Carly.
Thank you.
Thank you.